Okay, it gives me great pleasure to introduce for this podcast my good friend and colleague, Dr. David McIntosh. Quick preamble for David. David did his medical degree in Adelaide and did his enos and throat training in Australia before moving to New Zealand to undertake a pediatric fellowship in enos and throat. Um, uh, he has a PhD and his thesis relates to healing after sinus surgery, of which he's an expert. But I think the reason I've asked David to do this interview, other than one of 100 other enos and throat doctors that may be available, David has a very good understanding of facial growth and development and how it relates to nasal breathing, and he works a lot with dentists. And for many parents, that could be a better understanding of why their dentist may be suggesting during a dental checkup that the child has an airway-related problem. And David's very proactive in the social media sphere in educating parents and hence helping children. He's written 7 books which are available on Amazon. And I'll probably start, David, by asking the classic question, which is addressed nicely, and I think your first book, Don't Ignore the Snore, right?
Yeah.
And that is, when I talk to parents about their children snoring, they kind of view it as a comical thing because, unfortunately, in the media, TV, cartoons, the children snoring is always associated with some sort of humorous situation. And I even had a mum the other day that said to me, "Look, I don't know who snores louder, my husband or my child. It's a bit of a contest," and she sort of laughed it off. Yeah, do you want to start by just explaining to parents why it's so important that they are monitoring if their child snores?
Yeah, yes, absolutely. And again, Derek, thank you so much for having me here. The reality is, let's be honest. Yeah, snoring has been normalized and humorized. And look, I'm as guilty as anyone else. If we want to be honest, the way it's presented and portrayed, sometimes, yeah, it is. It does make you laugh. It does make you giggle. But we've got a distinction that needs to exist between what's there for our amusement and entertainment versus actually what's going on in an individual's life. And snoring, if we look at it from a medical point of view, is actually a real concern. It's a real concern in children. It's a real concern even in adults. The issue in either of those scenarios is that snoring is a noise that is made because there is some form of dysfunction of the airway, and predominantly it's some form of obstruction of the airway. So effectively, it's a sign of being choked internally for a plethora of reasons that could be causing that. So that's why we have this thing that I throw around of don't ignore the snore. It's because it's a warning sign. It's really like it's almost like there's a red light that's in the bedroom flashing, and the siren is going off. Emergency, emergency. So the concerns with snoring, if there's airway obstruction, comes down to sleep quality, and also a really important thing. It's the most important element for us, and that's oxygen. Of all the things that we want and need in life, the most essential of all of the above is going to be oxygen. And if you're not breathing properly, then you're not getting adequate oxygen, then there's a whole lot of problems underneath the surface that are going on. So, yeah, we really want to just emphasize that snoring really is a concern from a medical point of view.
How, when I ask parents, like, does your child snore? Of course, the first response would be, I don't know, I haven't slept next to the kid since he was 1 year old. Are there any apps, or I know sometimes you ask parents, look, take a photo of your kid while they're sleeping so I can look at their oral posture and if their neck is extended. Say a parent listening to this then realizes, look, I better go and check if my child snores. What would you suggest?
Yeah, so you're absolutely right, and it's totally understandable, especially the way that we've progressed as a society. We now have houses that have multiple bedrooms, multiple wings, and so forth. So it's not unusual that the parents have lost contact with their child at night just by that virtue of separation physically. So what I suggest the parents do is just pop in every night for a week or two. Just mix it up in terms of which time of night you go in, and just spend a few minutes in there, just looking and listening. Have a look. Is your child sleeping with their mouth open? Do they have their head arched back? Are they tossing and turning? And then have a listen. Are they snoring? Do they sound just noisy? Like teeth grinding as well can be going on. They can be having night terrors, which is where the child is yelling out, screaming, and so forth, and is really quite distressed. And
Yeah.
that sort of gives you an idea that there's, these are all signs. They're not conclusions, but they are all signs that your child has some form of breathing and or sleep disorder, and you can have one or the other or both. And this is a problem that we have as a society, is we really haven't focused as much as we should have on the importance of good quality sleep that plays into our health and well-being. And that is starting to change. People are starting to highlight sleep as a major part of our health and well-being, which is fantastic. But you got to get it right in childhood. There's the period of growth and development that happens is those early years. There's a doubling of size of things, and then doubling and doubling again, and it happens really, really quickly. And with that growth and development, breathing and sleep are absolute cornerstone foundation requirements to get the best of what nature has otherwise given you, to then proceed down the pathway of life.
And if we follow the whole parent scenario, so they've now clearly identified the snoring. They're aware their child doesn't is not getting restful sleep. How do they get to an ear, nose, and throat doctor? Does it have to be through the GP pathway? Because I'm asking that question because I know sometimes general medical practitioners, God love them, don't necessarily give enough credit to the mum, and will just pass it off and saying, "Oh, that's kind of normal. He might grow out of it." Blah blah blah. Um, can a I know certainly in my sphere, many general dentists refer directly to an ear, nose, and throat doctor for their patients. What about a mum who's concerned? Listen to this podcast, knows that her nephew snores loudly because they can hear it. How can they get to an ear, nose, and throat doctor like yourself?
Yeah, for sure. Now, look, obviously, it gets complicated in this day and age of technology because, your intention and mine is that everyone all over the world is going to be listening into this. So we have to acknowledge there's going to be geographic differences in healthcare systems. So, but my basic answer is, at the end of the day, you do want to have your medical team on board. You do want to have your dental team on board. So in an ideal world, it would be both the medical and the dental teams that would be writing to the ENT, sharing their concerns from their own individual perspectives. And we do have different perspectives. There's a whole lot of medicine and a whole lot of dentistry that feeds into this topic. And we can't expect the doctors to know dentistry, and we can't always expect the dentists to know medicine. But so, ideally, it would be a collaborative team approach. But, in terms of the pecking order of things, so that'd be the top of the tree. Then the
Yep.
next rung down would be one or the other. And then the
Mhm.
bottom of the tree would be none of the above. You can go
Right.
and see an ENT without a piece of paper that says, please see an ENT. This is Australia is a free country. We have rights of healthcare that are in our charter. It
Yep.
just really comes down to how it's funded, and having a referral changes the funding to something versus having no referral where the funding is nothing. So,
Got it.
so that's just sort of worth bearing in mind. If at the end of the day, the mum is just so worried and feel like that she's at a dead end in terms of getting that magic piece of paper, well, at the end of the day, you actually don't need that magic piece of paper. Um, you know,
And I'll use this opportunity to also add, I have a lot of experience in this field. As you know, next year is my 40th year in clinical practice, and the number of times a family have decided to go off and see their ear, nose, and throat doctor, meaning maybe a family friend or so, and they're quite dismissive of the, oh well, the kid has very large tonsils, but he's only 4. He's going to grow out of that. And they don't understand, much like you do, that even without infected tonsils. So even if a child has no episodes of tonsillitis in a year, their physical tonsils are blocking the airway, which is opening up a posture which affects their facial growth. Can I get you just to touch a little bit on why dentists would be sending to an ear, nose, and throat doctor, not necessarily if the tonsils are infected, but because they can identify that tonsils are blocking the airway?
Yeah, absolutely. So, look, one of the things you mentioned in the introduction is how I went and did a work in New Zealand. So that was a dedicated period of my life where, amongst the realm of the big specialty of ENT, all I did was pediatrics. So I didn't see a single adult for a whole year. And I just want to say that just to highlight that ENT itself is a massive specialty. You know, the fact that you can just spend a whole year just seeing kids under the age of 12, you know, and fill your time up and then some, is just to highlight that ENT is a massive specialty. And as a consequence of that, and as a consequence of the focus on what I do, I can tell you what my deficiencies are as an ENT. So I don't do head and neck cancer work. I don't do major ear surgery. I don't do, major, skull-based surgery. Now, these are all elements of ENT surgery. And likewise, not necessarily can it then be expected that every ENT does pediatrics or has done a pediatric, year whole dedicated, period of pediatric training. They might have done some pediatrics, like I've done some throat cancer work, but there's a big difference between, doing some of it and doing a lot of it. And that just sort of just molds us into the different types of ENT surgeons that we become. But in the context of that then is that our fields keep progressing and developing, and having kept my finger on the pulse in terms of the airway side of it, that's why things like you've highlighted, it was exactly what I was taught initially, is that, oh, they'll outgrow it, it's not that bad, they haven't had tonsillitis, so that they were my foundation years of growth and development, which over time have been proven to be wrong. But unless you've focused on this, you may not be aware of those proofs and changes in things. So we know a huge study that was done in the United Kingdom where they looked at 12,000 kids, of which a good number developed airway problems. But they took the philosophy of exactly what it was at the time, just let them outgrow it. And lo and behold, some of them did. However, and this is the important thing, is they actually looked at their health outcomes, and their health outcomes were not good. These kids that developed airway problems, especially early in life, you mentioned the 4-year-old, those children were having learning and behavior problems later on, compared to kids that had never had airway problems. So that sort of raised the red flag. So then the next study came along 3 or 4 years after that, where they said, all right, well, we're going to find these airway problems, but we're going to split these kids into 2 groups now. We're going to split them into half we're going to fix, and the other half we're just going to leave them be. And again, the ones that they sort of ended up with 3 groups. They had the kids that they'd fixed. They had the kids that they didn't fix, which in inverted commas got better. And then they had the kids that they didn't fix that didn't get better. And the time frame was 6 months down the track. So not a huge period of time. But that's all it took for basically to see that there was massive differences. So the kids that got fixed 6 months later were fantastic. The kids that didn't get fixed, but in inverted commas, got better from an airway snoring point of view, they were not doing very good. And the kids that didn't get fixed and didn't get better were doing even worse again. So the moral of the story is that the airway problems are causing damage. They are affecting the trajectory of and well-being of this child down the track. And the science is well and truly on our side now, that the early identification and early intervention gives you a much better platform for growth and development and well-being. And it only takes 6 months of what effectively now could be called supervised neglect to lead to these problems and damage down the track. So that's the side of the fence from a medical point of view. Now, and this is where the dentists are really showing their worth in this arena, because if we just think about it anatomically, everything that you and your colleagues do, it's all centered around my territory of nose and throat. We are in the same neighborhood. We're looking at it, from slightly different perspectives, but as we sort of grow and build our relationships, we're actually having shared perspectives here. So I'm on the lookout for dental things, and I'm not a dentist. Everything I have in my back pocket is simply because of this integrative approach, where having been immersed within the dental community and starting to learn things. So, and it's really, really eye-opening. So, we look at mouth breathing, which sounds pretty innocuous, the mouth breathing. But the effects on the mouth and the jaws and the teeth are phenomenal. So it's a leading cause of gum disease. It's actually a leading cause of getting holes in the teeth. So people think about, kids, hole in the teeth. Oh, yeah, it's because they're eating too much sugar. Well, mouth breathing actually causes more holes in the teeth than sugar does. Mouth breathing is actually more damaging to the teeth than a really, poor diet and so forth. And then, we start seeing all these orthodontic problems. The teeth are growing crooked, but far more greater concern to me is the jaws are not growing properly. And it's
Exactly.
specifically the underdevelopment of the jaws. And the reason that's a concern is because, as I've come to learn, most jaw growth and development happens well before the age of 12. And I think the statistics are 80% by the age of 8 and 90% by the age of 12.
Exactly.
So what that means is that when we sort of then look at the trajectory of that person that's basically set up with poorly developed jaws, is that's going to translate into an adult with poorly developed jaws. And we already know from a medical point of view, when we look at obstructive sleep apnea, that people with underdeveloped jaws are at a huge risk of developing obstructive sleep apnea. And we also know one of the treatments for it is major jaw surgery to basically re-break the jaws and bring them forwards, or the middle of the ground approach, which a lot of people obviously gravitate towards, is having a mouth guard splint that holds the jaw forwards. Now, the only reason we've got to hold the jaw forwards is because that jaw hasn't come forwards by itself naturally in the first place. So,
Yes.
These are really the big red flags, and also big opportunities. I think there needs to be a real shift in the paradigm from a medical point of view about early identification and early intervention. And I would like to see that also happen in the orthodontic arena, where we can get more dentists and orthodontists on board with early interceptive orthodontics, not so much from the teeth point of view, but specifically from the jaw point of view. And you might have some insights there that are worth highlighting as well.
Absolutely. In fact, I interviewed Bill Hang years ago, and he coined the term airway orthodontist. And so sometimes parents say, "What's an airway orthodontist?" And I say, it's someone who focuses on your kids' breathing and their sleep first and worries about straightening their teeth later. So an airway focused orthodontist will be asking the questions that I brought up. Does your child snore? How's your child performing at school? Do they wake up unrefreshed? And these conversation starters can then lead to a better understanding of the child's jaw and development. I mean, when I went to orthodontic school, we treated all the patients at 13 or 14. If there was crowding, we ripped out some teeth, we put braces on. I thought I was doing a wonderful job. Only when I was exposed to this concept that child will have problems for the rest of their life if you don't fix their airway early, that I started focusing on treating earlier. Now, I was thought I was doing a great job jumping from the 13-year-olds to the 7 and 8-year-olds, where I was able to easily expand the jaw. I was able to encourage forward growth of the jaws. But now I will treat a 4-year-old if there's a medical necessity. So, as you know, I get a lot of referrals from medical doctors, ear, nose, and throat doctors for a child who's been diagnosed with sleep disordered breathing. Now, if they have a narrow palate and they can't breathe through their nose, the literature is full of evidence to support early expansion. So I'm in my comfort zone now to expand a 4-year-old, because guess what? It's really easy to do. When I talk to some of my colleagues, they wouldn't dream of treating a 4-year-old. Some of them don't even believe in expansion. So that's why the term airway orthodontist is someone who's going to ask the questions about your child's sleep, look at their facial growth and development, and then worry about straightening their teeth if needed later. David,
Yeah.
one topic that parents always ask me, because again, there's so much misnomer, is the whole concept of nasal allergies, right?
Mm.
Now, I would say when I look at a medical history, and I'm looking at many new patients' medical histories every day, every child, the parent just ticks the word hay fever, right? And I say, right, well, what's your child taking for that? Oh, we just go get Claritine as needed, etc. Right? And I believe every nose and throat doctor in Australia is busier than hell, because pretty much every kid in Australia has some form of allergy. And I mean, you're up in Queensland. I'm currently in Melbourne, which I think it varies. What is the allergy capital of the world? But every second kid I see here in Melbourne definitely suffers from nasal allergy. So, can I ask a question? Can you define for a parent the common term hay fever, allergy? How do you diagnose it? What are modern forms of treatment? I mean, I know most common allergy is probably dust mite, one of the hardest things to eliminate or control. So, I get a lot of these kids and a lot of parents who understand that their child needs to breathe through their nose for good facial development, but it's the allergies that keep coming up. So, big topic, but I thought you could just, from a parent's point of view, expound a bit on that.
Yeah, absolutely. So, look, and again, this is where we're stuck in history, because literally when I grew up as a kid, if you had hay fever, well, look, there really wasn't much you could do about it. But yeah, I'm clearly have progressed a little bit from being a kid to where I am at now, and medicine has done the same. So let's forget about the past. Let's actually look at where we are. Where are we at right now in this day and age? So in this day and age, what we know is that allergies over the past 15 years in Australia have doubled in terms of nasal allergies, hay fever, which is having some form of environmental airborne trigger that causes a reaction in the nose. And when I look at nasal allergies, I break it down into two broad categories: an impact on the breathing and the everything else. So the everything else is the itching and the sneezing and the runny nose and so forth. But obviously I'm ENT, so my big one there is the breathing. So at the moment, the statistics is that it's roughly 1 in 4 Australians has some form of nasal allergy disease process going on. So that's why we're seeing so much of it. The other thing is that you and I obviously have a selection bias, because we see the nose problems and you see the orthodontic problems, but that's not a coincidence that we're seeing the same thing. And the reason for that is that we know that having nasal allergies ties in then with having breathing problems. We know
Yep.
from a paper that was published well over 10, 15 years ago, where they looked at a group of kids fronting up to an allergy clinic. So these are kids with hay fever fronting up to an allergy clinic, and they got some orthodontists to just look at these kids, look at their jaw growth and development. And the chances of having an orthodontic problem compared to a group of kids that didn't have allergies, it was three
Yep.
times more likely. So you're three
Wow.
times more likely to have some form of orthodontic problem if you've got nasal allergies in your history. So
Mhm.
from that point of view, there's a pretty significant thing there about nasal allergies and the impact on jaw growth and development. The other thing then is it impacts on the breathing and the sleep, which is a huge concern, because of the reasons that we've just sort of introduced. So you go,
Yep.
right, well, here's the problem. What do we do about it? Well, this is what we
Yep.
do this day and age. We've got to go through a process. And the process is trying to get symptom control. And initially, we do that with medications. And the first line medication is a nasal steroid spray, it's not the antihistamines. And the
Mhm.
reason for that is the antihistamines are good for the things like the sneezing, the itchy, the runny nose bit, but they do next to nothing for the airway part of it. The nasal
Right.
sprays manage all of the above. So, in terms
Yep.
of trying to get the best bang for your buck, the nasal steroid sprays are your starting point. And we do it
Yep.
as a trial, usually for around about 6 to 12 weeks, to clarify how much symptom control can we
Yep.
achieve. Now, as
Now,
part of
David,
that,
can I just ask one question there?
sure,
Um, I know Nasonex is now available over the counter,
yeah,
whereas rhinitis, etc., you still need a prescription. Parents are going to ask the question, right? Yeah, you're describing exactly my kid.
mm,
When do I know to use Nasonex? Can you just explain that point of view? Because many of these parents, particularly here in New South Wales, where there's such a difficulty just getting in to see your GP to get a prescription.
yeah.
And these parents who self-medicate and have Claritin always, in the bathroom, sure, they're now keeping Nasonex there as well. Can you touch on that point? Sorry.
Yeah, sure. No, not at all. So again, just being mindful that we might be using some brand names across the world that other people don't come across just because of how it's branded here. So and look, there's a multitude of things that are out there. So just to keep it generic, so that we don't cause too many elements of confusion. So yeah, there's a plethora of medicated sprays. Some of them are available over the counter here in Australia now. Some of them you do need a prescription for. And we might have one that we try. It's a bit like antibiotics. You get an infection, you try one antibiotic, it doesn't work. So it's not to say that you don't need antibiotics, but maybe we had a starting point, it was the wrong one, and we need to try a different one. So sometimes there can be some trial and error there. But what you do need is you need to have a proactive approach, regardless of how you're accessing these medications. Whether you need a prescription or not, you need to have your medical team on board. And again, this is where it's, like so many things, it's hard to keep up when there's so many changes going on. As I said before, I can't keep up with all the changes in ENT. So I don't expect, every family medical doctor to be able to keep up with all the changes in ENT either. But, we obviously just want some basics. So what I would say is that this is a great thing that, parents can use. Just bookmark this little thing and just say, hey, I just want you to see this bit where this ENT guy just said, if you've got nasal allergies, nasal medicated steroid sprays are the first line treatment. And we need to do that for 6 to 12 weeks to look at symptom control. And this is the other thing that we need to do, is we need to actually test to see what the trigger is. And this day and age, we can do that off blood test. And you need to ask for the right blood test. You need to ask for the blood test where they will cover brass, dust, animal, and mold. They're the big four in Australia in terms of categories. And the reason I emphasize this is, again, because there's a quirk here in Australia, at least, with medical testing on a blood test for nasal allergies, where they may only get 3 things tested for, even though we can test for 4. And the reason that happens is because of our Australian funding model. The Australian government has agreed to cover 3 out of 4 of those tests. So you can pick any 3 out of those 4 and get testing through the Australian government funding model that we have here. But to me, that's like saying, look, here's 4 corners of the room, and one of these corners of the room has got $1 million in it. But you're only allowed to look in 3. All right. Okay. So why would you not want to look in all 4? It's just like, well, if there's $1 million in this room and I'm already here, we're already doing a blood test. Why wouldn't you want to look at everything? So this is where you have to basically accept the fact that the Australian government, and every country will be different, but here, off the blood test, the Australian government's made that decision. So that's just the system that we've got. There's no logic behind it.
You've got to love Medicare.
You've just got to go that extra step. But this is really important, because parents will go and get the allergy test and say, oh, they didn't find anything, and then I'll have a look at it and they go, well, they didn't look for everything either. So if you haven't looked for everything, then there's a chance that you won't find everything. If it was a different context, say this was a blood test for cancer, all right, and say, look, we got a blood test, we can check for the 4 most common cancers that might kill you, okay, just off a blood test, and if we pick it up early, we can treat it now, and you'll live an extra 10 years, right? But we're only allowed to check for 3 out of those 4, unless you want to pay extra. What person in their right mind would not pay that extra money to find that cancer diagnosis early, to have it treated early, to live a better life? Nasal allergies are no different.
And on that point, parents ask me, well, what's the difference between skin prick tests, blood tests, and an airborne test? Can you just touch on that? Because that'll be of interest to parents.
Yeah, of course. So the advantage of the blood test is it's quick and easy, and we start getting some feedback really quickly. It precludes the need to line up to see an allergy doctor in an allergy clinic as a starting point, which can just add weeks, months, and sometimes even more to the timeline of getting an understanding of the trigger. Plus, off the blood test, if we've proven there's a trigger, it makes it much easier to get in and see an allergy doctor, because we've actually got documented evidence that there is an allergic process going on. And in the meantime, we can also then start giving the parents some basic things. So say, oh look, you've got a dust mite allergy, so let's go through the dust mite protocols. Or look, they're actually allergic to the cat, so at the very least, keep the cat out of their bedroom, and so forth. So we can actually start the ball rolling. The other thing I just want to highlight is off the blood test. The other thing that I personally add to the mix is measuring their iron level. And I won't go into the weeds today, but the simple reason I do that is that kids with airway obstruction, about a quarter of them have low iron in the background. And the low iron makes the breathing problem worse, and the breathing makes the iron worse. The other thing is that just having nasal allergies, just allergies by themselves, whether you've got a breathing problem or not, about a third of the time there's low iron that's caused by that for complicated reasons. And low iron then makes allergies worse. So the other
Yeah.
advantage of the blood test is I can check their iron level. And, I'm finding up to a third of the kids that I see as an ENT have low iron that hasn't been picked up on. And I can understand the challenges of getting a blood test done in a 3-year-old and a 4-year-old. But again, this is a medical problem, so we've got to have medical solutions. So there's that.
Yep.
And then, but there's every now and then where we find a kid that we're absolutely certain they've got allergies, but nothing shows up on the blood test. Well, that's the advantage then of having the skin prick test, where we can go, look, maybe, now and then it shows up on one test, but not another. It's a bit like having, what we call a CAT scan versus an MRI. They're both different, sort of scans, but one's can be, you can find it on one and not the other. Well, it's a bit like a blood test and a skin prick test. And it goes the other way too. We'll do the skin prick test and find nothing. So we go, let's just do the blood test just in case it shows up on that one. So it's just different ways of trying to find, underlying causes and problems to then, make sure that we're not missing things, and also strategize a plan. Because ultimately, if we can find what's triggering it, then we get the allergy doctors to help us to do some desensitization therapies, which is a process of trying to get the kids used to what they're reacting to, so that we don't have to rely on medication for symptom control. Because this is the important thing. Medication, it doesn't make the disease go away. It just makes the symptoms of the disease go away. You stop that medication, that disease comes straight back.
Okay.
The other thing then is how the surgery fits into the mix. And people can be surprised to learn that surgery is part of treating hay fever, but it is from the breathing point of view. So if we're doing the right things, but this child still can't breathe because their nose is blocked because of the swelling of the skin from the allergies, well, then we'll go in there surgically. These are things called turbinates. And again, the big words don't matter, but it's nice to have heard the word all the same. So, and we can do what's called a turbinate reduction, make these turbinates smaller, okay? But this, again, emphasizes the importance of addressing the underlying cause of the allergy, because if all we do as medical doctors is, ENTs, is just go and take the swelling away from allergies but don't address that allergy cause, well, that swelling's going to come back again. And then it's important, as you know, from an orthodontic point of view, like if we just do the expansion, just, expand the jaws out, but this kid still can't breathe through their nose and their mouth breathing, well, they're going to have this terrible word that, is like swearing to an orthodontist, called relapse. It's going to go back again, So, and look, I've seen it, you've seen it, we've seen these people, they've had their, traditional orthodontics as a teenager, and then they're coming back to us in their mid-20s, and it's all just gone backwards again. And you ask them the question, look, can you breathe through your nose? And they go, oh, no, I've had hay fever since I was a kid. And what do you do about it? Oh, I just take some antihistamines now and then and put up with it, because they don't know any different, So again, this just highlights, hopefully, to parents, that we want your child to be able to breathe properly. We want you to take a proactive approach to allergies. If you ever hear anyone say it's just allergies, go somewhere else, because we know it's not just allergies. We know that having breathing problems is a concern. We know that it increases jaw and orthodontic problems. It also impacts on mental health. There's research that shows that, kids that develop allergies in their younger years, by the time they're teenagers, they're more prone towards some mental health problems. So that is not just allergies. So I really just want to get parents on board here, and really change the narrative, where you start driving the bus for your kid, and you start being, their advocate for early approaches and interventions from a breathing, sleep, and orthodontic point of view, because your child is going to grow and thrive as a result of getting in early and getting things better.
And then on that same model, parents always ask me about deviated septums because as an orthodontist, as you know, we take the whole head x-ray and we can see that, albeit in 2 dimension, but nowadays most of us are using CBCT, so we can actually see that well, we can see the inflamed turbinates, but we can certainly look at the septum. Now, as I said, I mean, I think ears and throats is a chosen profession in Australia because if you're that one lucky kid who doesn't have allergy, we're a sporting nation. So there's probably a good chance you're going to damage your nose. Can you
Yeah,
talk us
absolutely.
through, timing of fixing a deviated septum? Because we both know that it is a growth center of the nose and something we probably can't repair early. But parents, of course, are concerned about it. And in the same way, it's affecting breathing and all the things we've discussed.
Yeah, absolutely. So again, when I went through my training, and I've been to courses and conferences, I've seen people literally get into verbal jousts and arguments over this very thing. So that's how controversial and contested this topic can be. But what we've got to do is just back off for a moment. We've got to look at the history, but then we've got to look at the science. So the history was don't touch them, just leave them
Yeah,
alone, because if you start doing things to them, the nose isn't going to grow properly. Okay.
yeah,
And
yeah,
that's where they ended the story. But what
yeah.
they missed was that, hang on a sec, you got a child that's not growing and developing properly, and
Yes.
their mouth breathing. And then they looked at, right, so what happens to this child as a result? And what does it do? It increases cranial growth problems, so jaw growth problems. So it
Mhm.
actually contributes to poor jaw growth and development, which means that we go from having one problem to two problems.
Yep.
And
Yep.
both of those problems combined then respectively and collectively impact on breathing and sleep. So by
Yes.
leaving a problem on the table, we're actually making another problem come to the table, and those two things together are bad for this child.
Yep.
So
Yep.
we've got that in our back pocket as a starting point of causing problems.
Hmm.
And then we could look at those brave souls that go, well, look, maybe we can start fixing these septums in kids. And they started doing it, and it started working, and we weren't seeing the major problems. Yes, we need to be very careful, we need to be conservative. There's issues about growth and development and interfering with the same, but we're basically choosing a much better option by actually addressing it. So just for personal experience, which is just obviously anecdote, the youngest septum that I fixed was in a 4-year-old. Okay. All
Yeah.
right. And then I would commonly be doing 6, 7, 8, 9, 10, 12 year olds, and often these are kids where they have been told, that you got to wait until they're 16, got to wait until they're 21, you got to wait until they've stopped growing. And
Yeah.
and that certainly was the teaching and the paradigm. And
Yeah.
and I'm not saying that those that are giving that advice are wrong, but I think we just need to acknowledge there are different philosophies out there, and the one that I have is grounded in the science and the literature, and then sort of built on from that is grounded on what is now nearly 20 years of experience clinically of actually fixing these things in kids. So from that point of view, I am not seeing the problems that people are catastrophizing are going to happen. What I'm seeing is children that are growing better and sleeping better and breathing better. And some of these kids, everything else has been fixed. They've had their tonsils fixed, they've had their adenoids fixed, they've had their nasal turbinates fixed, but they've still got that deviated septum, and no one will touch it. And this kid cannot breathe properly. This kid's waking up absolutely exhausted. They've had the expansion. They've had everything. They just need that septum fixed. So
Right.
again, parents should always feel empowered to seek out additional opinions and respect the opinion that they're given, but also know that at the end of the day, it's not the only opinion that's out there. So they can sort of do their background checks, and if it means they've got to jump in the car and go for a bit of a drive and a journey across town or the like just to get that, well, look, do it for your child, because we're talking about the lifetime of your child versus an hour or whatever it takes, time wise, investment otherwise, to really potentially change their life. As you sort of said, I really am quite an advocate and passionate about this topic because I really want to see our children thrive, and to do that they've got to breathe properly and they've got to sleep properly.
And let's talk about another controversial topic. I mean, all over the media at the moment, there's a shortage of Ritalin and Concerta and everything else to treat ADHD. I think you and I know that many of the ADHD kids, the diagnosis is fundamentally flawed because no one's done a sleep study. Can you just share with us your knowledge on that
Yeah,
topic? Because
yeah,
again, in medical histories, not only am I seeing, the tick hay fever, but every form of, ASD level 1, 2, 3, ADHD, and it's just more and more common these days. I
yeah.
feel a lot of it's linked to sleep. Do you want to share your thoughts on that?
Yeah, absolutely. So the pivot point for me was actually when I was in New Zealand doing that pediatric training, and it was
Hmm.
in. I remember it exactly. I'd been there for less than 3 months. Okay, so this just to give a timeline. So that was in 2006.
Yep.
Now in 2005, New Zealand as a country, because they have a very good healthcare approach where they can write things for their country. They don't have to go, well, this is what we do in New South Wales and this is what we do in Victoria. It's
Yep.
countrywide. So
Yep.
they had literally just finished completing their pediatric guidelines for tonsillectomy surgery. And at the top of the tree, they had put airway and breathing. Okay. And
Hmm.
what happened in March was this paper came out where they had a group of kids coming to an ENT clinic, just like they do all the time, with this diagnosis of not being able to breathe properly, and we're going to take their tonsils out. But before they did that, they got the psychiatrists and psychologists to assess these children for ADHD, and they found a huge number of these kids ticked all the boxes for ADHD. Okay.
Wow. Yep.
So and then they did the surgery and they got those
Hmm.
kids checked 12 months after. And pretty much the majority of those ADHD, symptoms and technically could have been an ADHD diagnosis. Like they actually ticked all the boxes. A
Yep.
huge number of them were gone. Okay. So there was like a big wake up call to the fact that had these children not actually been picked up with a breathing problem and
Yep.
instead had been picked up with behavior, concentration, learning problems, and had
Yep.
seen the psychiatrist, and the psychiatrist ticked the boxes and said, yep, you've got ADHD, here's your medication, let's see if we can improve your concentration and focus,
Yep.
then we would have actually had a missed diagnosis of the sleep problem, and we would
Yep.
have a misdiagnosis of ADHD.
Yep.
So,
Absolutely.
then what people said is, let's look at it from the other point of view. Let's take a group of kids that we've said have got ADHD, and let's screen them for breathing and sleep problems. And in those kids where we find it, let's fix it. And what happened is, depending on which research project you look at, 25 to 50% of the kids that had ADHD as their starting point were found to have airway problems that were fixed. 25 to 50% of them no longer had ADHD.
Wow. That's
Okay.
that's amazing. Yeah.
They're huge numbers. Okay.
Yeah.
And then what we learned is that you can actually have both. You can have ADHD and breathing problems. They're
Yep.
both correct. But those children where you address the breathing and sleep problems, a good number of them still needed medication, but they
Yep.
needed less of it. Okay.
Yes. Right.
Because you
Yeah.
weren't actually counteracting the additional deleterious effects of having a breathing and sleep problem on top of the ADHD just with
Yep.
medication.
And I think if I can use this time to explain to parents that the signs and symptoms and behavior of a child that's not sleeping well mimic some of the classic symptoms of ADHD. Like if you're a parent and you're not, you haven't slept well for a couple of days, you always get up, you're lethargic during the day, you need an energy drink every, by
Yep.
by the afternoon.
Yep.
Children are offering.
Yep.
If children tend to react to poor sleep by becoming hyperactive. If anyone's had young children and they stay up 1 hour past their bedtime, they start climbing the walls. So
Yep.
so this hyperactive behavior, kids react and they react differently to adults for poor sleep.
Yep.
We could almost do a whole other 1 hour podcast, David, on that topic
Yep.
in the thing. But very interesting for parents to understand that it all leads back to proper nasal breathing, linking to their sleep, leading to their facial growth and development, leading to their kids' attention. So I love that saying you just said. We want all our kids to thrive and be the best they can be, and I think
Yeah.
a lot of that starts with their airway. David,
Absolutely.
do you want to just talk a little bit about resources for parents. I know I've written it. I'm sorry, I haven't written. I've read at least 3 of your now 7 books.
Yeah,
Can you do a deep dive into what you cover in these books
yeah,
and
sure.
how parents can get them?
Yeah, absolutely. So the great thing is that these are all on Amazon, so they're available worldwide. So you just got to jump onto your local Amazon store, the different books have different contexts. So we have you mentioned one, so don't ignore the snore. So that what that one does is that one goes through all the sort of research and literature about how having airway problems affects children and adults in terms of their body systems, whether it's from the effects on their heart, the effects on their brain, the effects on their gut, and mental health. Goes through a whole list of things there, with some science and references, so you can see the sort of efforts that has gone into understanding this topic.
Yep.
We have Snored to Death. So Snored to Death goes through in kids and adults, but it's more geared towards adults, but it does address kids as well.
Mhm.
About this diagnosis of obstructive sleep apnea, and this typical journey where people snore, they get a sleep study, and they're given a CPAP machine, and no one ever looks. No one checks why they got sleep apnea. Are there things that can be done to help their sleep apnea be less of a problem? Are there things that can be fixed so they don't even need the machine in the first place? Or if they're
Yeah.
struggling with the machine, what other options do they have?
Uh-huh.
So
Uh-huh.
that's don't ignore the snore. And then we've got what's called Sleep Disordered Breathing, a parent's guide. So this is the one for the kids. This is kind of like my roadmap for parents who, have got this problem, and they're trying to get answers, and the answers aren't forthcoming, and they're sort of going from pillar to post. Well, this actually gives them the roadmap. So think of it, kind of like you're going on a holiday to Italy. So what do? Well, you download a travel guide.
Yeah.
It's got
Yeah.
maps, it's got places to go, things to do, things to be aware of, and so forth. Well, that's what this is. That's the equivalent of navigating your way through that diagnosis. There's one that's just about sleep, so it's just a parent's guide to sleep, just explaining, because we're not taught this, we're not trained in this. As parents, we got our kids and we just want them to go to sleep so we can go to sleep. Well, it
Yeah.
just goes through whole things, things that we haven't touched on, things like sleep hygiene. What's a normal amount of sleep? What are the signs of a sleep disorder? It doesn't just have to be a breathing one. There's a whole range of sleep disorders. What are the sort of signs that your child has a sleep problem that needs to be attended to?
Mm.
So we have that one. Then we have the ABC of ENT, ASD, and ADHD. So this is just what we were talking about just
Yeah.
before.
Yeah. Yeah.
Yeah. So, and then
I
what I
think I
did is,
think any parent who listens to this podcast who has a child who maybe quickly diagnosed sometimes by a school teacher of having inattention disorder should get that book. Sorry,
yeah,
David. Yeah.
yeah, no, no. Look, I know I'm biased, but yeah, look, absolutely. That book is in the top 100 Amazon for its category. Okay.
Wow.
All
Wow.
right. You know,
Yeah.
it this book is getting a huge amount of traction, and I'm getting a huge amount of feedback from the world, because obviously, Amazon is the platform that's worldwide, where parents are going, we finally understand this now. I
Mm.
always knew that there was a piece missing. That it just didn't fully add up. I
Yeah.
couldn't put two and two together, but now I get it, and now this makes sense. It all comes together.
Yeah.
So from that point of view, that book is just flying off the shelf, and it talks about the breathing and the sleep, but it even talks about simple things like ear infections. Okay,
Yeah.
it
Yeah.
talks about allergies, it talks about iron, it talks about gut problems, and how these things are all interplayed. And the big problem that we've got in healthcare is that it's all split out into different sections. Okay,
Yeah.
so
Yeah.
it's like your kid's got ADHD. So who do they see? Because the school teacher picked it up. Well, they go and see the psychologist, and the psychologist gets the pediatric psychiatrist or developmental pediatrician, and they just tick the boxes in terms of ADHD. We look at the other bits and pieces, we find the other bits and pieces. So
Uh-huh.
so
Uh-huh.
so from that point of view, that book's got a huge amount of information there for parents
Yeah.
to really get things sorted. And then one of the more recent books that I put out, and this was a play on words, so I'll have to explain this. It's called Mental Health, but what I did is I put all the characters in lowercase, except in mental. The ENT part of it, I
Oh,
capitalized.
great. Yes. Yeah.
Okay. All right. So
Good.
that was so that was the play on the word, but it's a visual one, rather than a verbal one. And that one is highlighting the huge amount of mental health issues that tie in with ENT. And I talk about depression, anxiety, schizophrenia, bipolar affective disorder, PTSD, ADHD again. There's a whole huge list of mental health diagnoses that have ENT interplay. And if you don't know these links, okay, you're going to again be missing part of the story. We've got to come back to treating patients. We've got so conditioned to treating conditions. Like orthodontist is about fixing crooked teeth. Well, no, it's not. It's about getting the jaws right so that the teeth have got a foundation
Absolutely.
built upon. So this is where you got to look at the big picture, not just my child has crooked teeth. Well, your child might have crooked teeth, but they've also got jaws that are no good. We can fix one or the other, but let's do the right thing. Let's fix both. So from that point of view, that's it. And then the one that I'll advertise now, but it's still a work in progress, and it's going to be the same plan. It's going to be dental health. And again, it's all lowercase, but with the ENT part emphasized, where I go through the dental part of it, because, I think it's really helpful for the dental community and the medical community to be holding hands here. Of all the medical community, of everything that's out there, the one that is front and center, that is closest to dental, is clearly ENT by far. So from that point of view, I genuinely believe every single dentist in the world needs to have an ENT in their back pocket as a resource. And likewise, ENT should get used to working with dentists and start learning the language.
If I can make one point in that sphere, I'm on the AA both in New South Wales and in Victoria, and every time Dental Health Week comes up, it's the same old, reduce your sugar intake. But how many dentists are aware of the adverse effects of mouth breathing on the teeth and gums? And that's huge, and I get parents all the time. They say, look, I know my kid has a good diet because they're the helicopter parent that makes sure the kid's not eating junk, and maybe he sneaks something in at school. But they say, look, my kid's still getting cavities. And I look in the mouth, I see that, classic mouth breathers gingivitis. I see the high palate. I see purple at the base of the palate, not pink. And, you ask the question, you start that conversation. Does your child snore, et cetera, et cetera? So, really, really important point. Thanks.
Yeah, no, I agree. I mean, and just to give parents a number, so that, the science shows that if you take 100 kids that are mouth breathing, somewhere between 90 to 95 of them will have holes in their teeth.
Wow.
That's how dramatic it is.
Yeah.
Okay. And that can be just little, the minus beginning of a problem to the full blown, tooth is rotten and ready to fall out of whatever's left of it. So, the parents are right, and so forth, that, the kids' teeth are no good and their diet is perfectly fine. People are missing something. So this has to be front and center to, Dental Health Week is mouth breathing. The missing link. The seventh book on the list is basically just an overview of ENT. So it's a parent's guide to ENT. So, your child needs grommets. What does that mean? Your child's got allergies. What does that mean? Your child has got problems with their tonsils because of breathing problems, or it's because of tonsillitis. What does that mean? What are the adenoids? Where are they? Why do we fix them? Your child's got something called laryngomalacia, which is a floppy voice box. What does that mean? What do we do about it? Why do ENTs want to know about reflux and a multitude of ENT diagnoses, so that we can actually explain these things in English. And it's coming from a medical professional. Look, I'm not naive. I know you can go look this stuff up. We've got all these sort of technology things, but these technology things are, just running off of bulk information and taking averages. And they're pretty good. Let's get credit for it, but it's not the same as getting it from someone that actually does this day in, day out.
When people when people Google, sometimes they get the wrong information. So I think
Oh,
it's good you put
yeah,
it in a resource. In fact, if
yeah.
I can add this point, which links to all your books, I buy them in volume. I give them to parents before I say refer off to an ear, nose, and throat, or if I feel there's a thing. And then, the parent returns them, hopefully. I put them in the waiting room. And guess what? They always disappear from the waiting room.
I was about to
And
say
then,
that
yeah,
they go out and they never come back. At your clinic and clinics across the world, it's the same story. It's just like,
and then I,
we
and I-
need it, we need another 20, David. It's like, oh, well,
yeah,
that's good. Like, how
yeah,
many things have you got lying around? They go, oh, two. But I
yeah,
sent you 20. They go,
yeah,
yeah, people keep taking them and they never come back.
exactly.
You know,
And,
and
and,
because I
and what
think
I've,
what happens
yeah,
is they get their kids sorted, and then they
yeah,
pass it on to their brother or their
exactly,
sister or their,
exactly.
whatever. And it's just
Yeah,
like, I think you need to read this. And then
yeah,
there's another kid. And, I love the fact at the end of the day that
yeah,
I can share my knowledge and that there is literally hundreds of thousands of kids out there
yeah,
that are
yeah,
going to benefit from what I know without them needing for me to physically be the
yeah,
person that fixes it, you
yeah.
know?
That's great, great.
Yeah.
And I mean, my small contribution, which I'm working on, was that summary of all that PhD research I did. But again, in parents' information, I'm in the process of writing a book called "What's the Best Age to Take Your Kid to an Orthodontist?" Because that's
Yeah.
controversy in itself. But linking up all these airway, etc. I
Yeah.
mean, it'd be great one day, David, where when you check into a hotel room, in the top drawer you don't have the Gideons, but you have one of your books. That'd be fantastic.
Yeah, yeah, yeah. Well, we just got to fix one kid at a time, right? Like it's
Yeah,
that whole Mother Teresa principle is that
correct.
even if you can't save the world, you can still save a person,
Yeah.
and
Look,
you do that one at a time.
now one last topic, again controversial.
Yeah.
The use of CPAP
Yes.
in children. Now,
Yes. Yeah.
I when I did my sleep medicine training, uh, was taught the importance of CPAP in the short term, but I've now realised with a number of my own case studies and the
Yep.
literature, long term usage of CPAP for a child actually affects the growth of their jaw. So you're
Yes.
fixing one problem, but you're creating another. Can you touch a bit on that?
Yeah, we certainly can look, and we need to be careful because we cannot dismiss the role and need for CPAP in certain cases at certain times.
Yeah,
And I think in the mainstay, big front and center one of that would be things like premature children, children that have marked, craniofacial abnormality growth problems, and significant, so we're not in a position where we can generalize to give it an answer here. But
yeah,
if we're talking about an otherwise normal kid that's say 4 years old, you
yeah,
know, and they're put on CPAP, again in the context where they haven't even checked for the ENT problems. Okay,
yeah,
they haven't
yeah,
checked for the tonsils, haven't checked for the adenoids. They've got your kid snores, you got sleep apnea, and they give you CPAP. The parent doesn't want surgery, so they go for CPAP.
yeah,
Okay, all
yeah,
right. So we're all very respectful that there are options and choices and decisions, and we
yeah,
understand people's hesitancy about surgery, but you've also got to know risks and benefits. Okay, and
mhm,
and this is the big one I think is that with the CPAP, when you strap it on, you're holding the jaws from growing forwards just by virtue of the fact of just strapping. It's a bit like there's the tradition of foot binding. If people can sort of be familiar with foot binding, was a thing where in certain Asian cultures they would deliberately strap the feet up so the feet would not be able to grow so much. They were constricting the growth of the feet. So you can sort of look up that as a context. Well, this is kind of the same outcome by putting that strap on front and center, front of the face, goes around over the head to the back of the head. That's what straps it on. Well, that is holding that head from growing forwards every
yeah,
night.
yeah,
And we know that when we see these kids down the track, they've got marked skeletal deficiencies,
yeah,
which then has left them with an ongoing airway problem of making. So I certainly don't want to disparage the treatment as an option, and
yeah,
I understand and respect parents' decision-making processes, but I
yeah,
also want to highlight to parents that it may not be the be-all and end-all that you think of,
yeah,
of, of trying to avoid surgery. if
Yeah.
that's been suggested, and this has given
Yeah.
us the alternative in terms of what other problems might be down the road.
Yeah. Yeah. Perfect. David, always a pleasure. I always learn a lot when I have a chat with you.
Cheers, mate.